Today we're going to take a look at what happens when a committee sitting in an ivory tower tries to solve a complex socioeconomic and cultural problem. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal. I'm a primary care physician in Connecticut and I run my own medical practice. The complex socioeconomic and cultural problem we are looking at today is obesity. And the solution to obesity by the powers to be that control healthcare today is to create a quality measure and hold frontline doctors responsible. So in this video, we'll break down the BMI screening and follow-up plan quality measure and look at the problems it causes. I'll show you how this quality measure gives the impression of taking action to solve obesity, does nothing to solve the problem of obesity, but increases busy work for busy frontline clinicians. The definition of BMI screening and follow-up quality measure is the percentage of patients aged 18 years and older with a BMI documented during the current encounter or within the previous 12 months, and who had a follow-up plan documented if the most recent BMI was outside of normal parameters. Let's break down the quality measure into its individual parts. First is the denominator, which defines the total number of eligible patients, which in the case of BMI screening includes anyone over the age of 18, had a valid patient encounter based on CPT codes in the past 12 months, and the encounter was not via telehealth. The numerator includes the height and weight values taken during the medical encounter, and if the BMI is less than 18.5 or greater than 25, the doctor needs to document a medical plan to manage overweight or obesity. This medical plan needs to be documented on the day of the encounter or within the last 12 months of the office visit date. By the way, if a patient tells me that their height and weight, I'm not allowed to use it. My staff has to measure their height and weight and then put that one in the medical record. However, healthcare is complicated, so we need to exclude some people from this measure, either because it's useless or it can actually cause harm. So per the definition, we exclude people who are in hospice or who are pregnant. The way these people excluded is by using a type of billing codes called HCPCS, pronounced HCPCS. Next is the denominator exception, which is different from denominator exclusion. In this case, people are removed from the denominator only if the examining doctor justifies that it is not medically appropriate, or it just doesn't plain make sense to put a person through medical treatment for weight loss. Examples include the patient refused to be weighed, appropriate medical reason as to why reducing BMI may complicate other conditions such as nutritional deficiency, physical disability, or dementia, or the patient has an urgent or emergent medical condition where any delay would jeopardize health. Next is the reporting period during which quality measure applies. This is generally between January 1st to December 31st. And last are the data sources that will be used to calculate the quality metric. These data sources are generally billing codes, or they may involve a manual review of the medical record to find the documentation and submit it to the insurance company. Now that we know the details of this quality measure, let's analyze its rationale and if it is achieving its intended outcome. If I had to sum up the rationale for creating a quality measure for obesity, would be the following 2 points. Obesity rates are rising, and we need to ensure that doctors are screening and treating obesity. Now let's take a look at the problems this BMI screening and follow-up plan quality measure creates for frontline doctors. The root cause of obesity is a complex mix of socioeconomic and cultural factors. It is well documented in the medical literature that obesity itself increases the risk of several medical problems, including heart disease, stroke, and arthritis. The BMI screening and follow-up plan focuses on screening and treatment, while ignoring the structural reasons for obesity. In my first video from doctors to social workers, I talked about how our government has abandoned the responsibility of providing basic infrastructure needs to keep people healthy and has created an environment to transfer this responsibility to your local PCP. Let's take a look at how creating infrastructure to keep people healthy is way more beneficial than your PCP talking to you about diet and exercise. Here we're going to follow 2 populations similar to my prior video on doctors to social workers. The first population is higher BMI and the second has a normal BMI. Now again, we are trying to keep this very complex topic very simple, so please bear with me. Some risk factors for this difference is attributed to access to cheap, high-calorie foods, less education, less access to parks, walking, and bike lanes, which leads to decreased physical activity. As compared to the population with normal BMI, who can afford healthy food, they have higher education, and they have more easier access to parks, walking, and bike lanes, which leads to increased activity during their lifetime. The population health intervention in this case could be making it easier and more affordable to access healthy food, improve education by paying teachers fairly, and giving them more resources so that they can do their job well, building parks, walking and bike lanes so that there's increased physical activity during lifetime of a person. As you can see, a lot of these interventions are at the level of the government and will be way more effective than documenting a follow-up plan for obesity in the medical chart. The next problem with this metric is in people whose BMI fluctuates around 25. Let's say a person has an annual physical in May with their PCP, and the documented BMI at that time is 24.5. Since BMI is normal, the PCP does not document a treatment plan at that time. In December, the patient was seen for a common cold and their BMI was then documented as 25.5. It is winter and the person was wearing winter jackets and boots. If the PCP does not document a BMI plan in December because they focused on taking care of common cold, they are considered non-compliant. And remember, we cannot document the weight if the patient says that their BMI at home was still 24.5 on their own bathroom scale that they took that morning. We cannot use those numbers. We have to weigh the patients ourselves. The next problem is with insurance coverage. There are different treatment plans with varying degrees of efficacy for obesity. These include lifestyle and behavioral therapy, including intensive behavioral therapy, weight management counseling such as with a dietitian, medications such as GLP-1 agonists like Wegovy or Zepbound, and bariatric surgery. However, insurance coverage for these treatment plans is variable at best and non-existent at worst. If insurance does decide to cover medical treatment, they bury doctors under prior authorization. Essentially, PCPs are being asked to manage obesity without access to any tools or resources. If people are interested in obesity treatment, most of our conversations end up with, yeah, your weight affects your health, but unfortunately your insurance won't cover any treatment. So let's get back to talking about diet and exercise. Also, if the patient wants to come back in a couple of months to revisit obesity treatment with their PCP, that visit is also not covered by the insurance most often. This is very frustrating, both for the patient and for the primary care physicians. And then there's the unintended impact on patient care. The BMI quality measure requires us to discuss and document a weight management plan every year, even when nothing has changed and insurance has refused to cover any treatment. This repeated education can make our patients feel lectured to or judged. Worse, some may even start skipping appointments or avoid seeking medical care altogether, even when they're sick, because they dread another conversation about their weight. The BMI measure is also a canonical example of Goodhart's law in action. All it achieved is better documentation, mainly via automated or semi-automated copied and pasted phrases to ensure compliance. And it increased the burden on PCP offices to collect and submit data, allowing administrators to claim that they're providing good quality care. Now that we understand the problems associated with BMI quality measure, let's discuss some tools and techniques that PCPs and ACOs can use to improve the performance. There are two components to compliance: measure BMI and document a plan if BMI is abnormal. BMI measurement is not an issue in most PCP offices. As mentioned in my previous videos, the problem is data collection and reporting to insurance companies. So we're going to focus on how to collect and automate reporting. The first thing to automate is the documentation plan, irrespective of BMI status. This is already happening in most institutions. Most electronic health records can be set to automatically populate standardized documentation during an annual physical, something like patient counsel on healthy diet and exercise for weight management. This can be achieved using EHR functions like an encounter plan or dot phrases. I will caution here though, providers do need to talk to their patients about weight management. Documenting care in a medical legal record that was not provided is considered a fraudulent documentation. Please keep that in mind when auto-populating text in the medical legal record. Then there are the ICD-10 BMI Z codes, which are similar to the $0 CPT-II codes. I discussed CPT-II codes in my last video, the devilish details of data collection. The problem with these Z codes is that most doctors don't know they exist or how to use them correctly. There are two ways to solve this problem. Use certified coders to build the $0 BMI Z codes. However, this approach is expensive as PCP offices need to hire more staff. Or the EHR software makers can develop functionality, automatically add BMI Z code to the bill based on the documented BMI. I am not aware of this functionality in major EHRs today, and this is an opportunity for vendors. Next is the CPT-II codes. As far as I know, only one CPT-II code exists, and I don't know how many insurance companies accept it. 3008F, which body mass index documented, that is the CPT-II code. An automated workflow during an annual physical may drop the CPT-II code 3008F with the appropriate ICD-10 BMI Z code. As far as I know, again, this has not been automated in most EHRs and again is a development opportunity. Next is using HCPCS codes when billing Medicare. CMS defines a few HCPCS codes that function similarly to CPT-II codes. That is, they are $0 codes to report quality. Again, like CPT-II codes, these codes indicate to CMS if the patient should be excluded from the denominator, and if included, if the clinician met the metric. Similar to our last workflow, the EHR could automatically drop the appropriate HCPCS code based on BMI and a standardized documentation plan. I'm sure your head is spinning with all of these different codes. To make matters worse, some insurances accept some codes but not others. And if we submit more than 6 codes in the bill, we're not sure if they'll be counted. One way to get around this issue of ensuring the appropriate code is submitted to the appropriate insurance company is to develop an even more complicated workflow. When the patient comes in for an office visit, the system checks if it's an annual physical. The workflow stops if it's not an annual physical. If it is an annual physical, then the EHR looks to see if BMI has been documented during that visit or in the last 12 months. If there's no BMI documented, then it alerts the staff to document BMI. Once the BMI is documented, it continues to the next step and checks for the insurance company. Depending on the insurance, a HCPCS code is billed, for example, to Medicare, the CPT-II codes to commercial insurances, and no codes, for example, to Medicaid, as the entire bill might be rejected. Again, this is a simplified example to illustrate a more complicated workflow. The hardest part is to identify which insurance will accept which code, and that changes frequently. This is where AI can help us. This AI-assisted workflow can help in 3 ways that I can think of. Retrieval Augmented Generative AI, or RAG AI, which can read and analyze all insurance policies on their websites, find out which CPT codes are accepted by which insurance, and then modify the logic in the electronic health record. It can analyze success and denials of past claims with different insurance companies, and then again use that information to modify the logic. And then it can also analyze insurance reports to ensure that PCP is getting credit for the codes that are submitted, and then modify the logic based on that. Targeted use of AI in this scenario could make a difference in ensuring that PCPs are getting credit for their work. Let's get back to medical reality. Manual data collection and submission to insurance companies. Medical practices can submit supplemental data to health plans using functionality in an electronic health record or from a data warehouse. The downside of this approach is that there's often no way to capture a follow-up plan. However, this is still useful because a follow-up plan is not required for normal BMI. Submitting supplemental data ensures that PCP offices get credit for reporting BMI screening for people with normal BMI, especially if the patient is not seen for an annual physical. By the way, CMS has an ECQM version of BMI measurement and follow-up plan quality measure. The details of this can be found on the CMS website. I hope this video has convinced you of the useless nature of the BMI quality metric. I also hope you find the workflows in this video helpful in designing interventions or products to help PCP practices meet this useless quality measure. You can find a written version with references to the material that I discussed in this video in the article section on PCPLens.com. Along with the article, I've also included a PDF copy of the official document of the quality measure and a list of all the CPT codes with their descriptions for you to download. There's also an audio podcast version of this video on PCPLens.com. Thank you for watching this video. Take care and goodbye.